Good evening, everybody. I'm Dr. 𝗗𝗲𝗃, the medical advocate, and I'm so glad to have you join me this evening for YouTube Live. Now, you might remember that last week we talked about medical advocacy. Who is a medical advocate? A medical advocate is one who steps up to the plate when it comes to their health. They're taking total control of their health. It's what I call pulling in the reins. And I became that by being a patient, not once, but twice in a span of 19 months. And I learned when I was a patient that I had to really step up to the plate and take care of myself. It wasn't just about taking a medication or having a specific procedure done. And I learned how to be my own medical advocate. And then my quest became to teach other people or to empower other people, my patients, my audiences, how to be their own best medical advocate. And that's what I do today. Now, 2 weeks ago, we talked about the traits of a medical advocate. And the first trait is embrace the power from within. Trust your instincts. You do have the power to do this. You do have control over your own health. And that's really the most important trait. The second trait is don't make hasty decisions. Now, I didn't have much of a choice when I was hospitalized twice for emergency reasons. But most of the time, we really actually research and do your research and make a cogent decision based on that. And that's really important. And the third one is know your body. Nobody knows your body better than you. When I take a history, I am really listening to the patient because they can describe their chest pain much better than I can. And I will often tell patients that you're your first, I'm your second opinion. And they look at me like in bewilderment. What do you mean? I say, well, because you are your first. You know your body better than anybody. So it's all about the power from within. So now that we've done that, we follow those prerequisites, where do we go from here? And that's what tonight is all about. So I devised this little system called Patient Bill of Rights. You do have rights as a patient. And again, that's taking the power. And the other is patient responsibilities. You also have responsibilities. Being a medical advocate isn't just as free as all that. It's making decisions. So and this is all described in my upcoming book, From Both Sides of the Table When Doctor Becomes Patient. But you're going to get a preview. The first right is the right of individuality. And I don't think anybody wants to be just pigeonholed. And, you have to go on this medication, or you have to go on this cholesterol. And this is really a very interesting thing because today, corporate medicine tends to be just that. We tend to have certain pathways and certain systems in place to streamline things. But in my 35 years of practicing medicine, I can tell you that every case is different. You really can't pigeonhole things. And I'll give you a little simple example. When I was on the patient floor about 2-3 years ago, I was discharging a patient who had had a heart attack and a stent. And the discharge planner, who's an RN, came up to me and said, Dr. Elkin, did you forget to put so-and-so on an ACE inhibitor, or maybe it was a beta blocker, I forget which. I said, no, I didn't forget. I just didn't think it was appropriate. And she said, well, your chart's going to fall out of compliance. And okay, so I had to go back to the drawing board there, and I had to describe why I didn't think the patient needed to be on a certain medication. So I refused to follow the norm because I didn't think it was appropriate in this particular case. Again, that's the right of individuality. The right of choice, okay? You have the right to expect the utmost and excellent from your physician, your hospital, and also the right to have someone who's compassionate, who listens to you. And that's very important because you can and you should demand both. And they are out there. You can find the right medical team that's out there. The next one is the right of encouragement. The act of giving hope and confidence. You don't want a grim reaper on your side. You want someone that's going to give you hope and confidence, no matter what your diagnosis is. Someone that's really feel is on your side. I've never said to someone, you have X amount of months to live, or I just always try to keep very positive and possible, unless I'm at the very end of the road here, and that's not usually the case. And then there's the fourth one is the right to be heard. Now, a lot of people feel that they aren't heard. In fact, that's still the number one complaint that most people talk when they mention about their relationship with their doctor, they don't feel heard. And that's been in survey from year after year after year. My mother used to joke and say, well, my doctor has 1 foot out the door and 1 foot in. You don't want that. You want someone who can give you that full attention. Now, along with those Bill of Rights, you have what's called patient responsibilities. And one is you have to be persistent. You may have to educate your doctor. A lot of doctors don't know about supplements. Some of them don't know about alternative aspects of healing. And you have to let them know that that's what you want and that you're going to do this, that there's nothing to be ashamed of. So there's a way you can guide your patients into your doctor into the right position. For example, a couple of days ago, a patient of mine told me about an interaction of a particular medication and her bone health, and something I was totally unaware of. It was great. I love to learn from my patients. I don't feel anything negative about that. So you have to be persistent, and sometimes you have to educate your health team. And the other one is you have a responsibility to be self-informed. Don't expect to get everything from the doctor. You have to do your own homework. There's plenty of material out there. So stay ahead of the game. Know your illness or your symptoms, embrace them, and do all the work you can. If it means getting a second opinion, go for a second opinion. And the other one is the assumption of financial responsibility. And this is a big one because I think we all can agree that insurance is paying less and less. We're paying more and more, and we're being awarded less reimbursement for services. So you will find out that certain tests aren't covered by insurance. For example, nutritional consult will probably not be covered. Certain functional medicine tests, like we're looking for micronutrient analysis or certain hormone levels or adrenal health. Some may be, but some may not be. And I will tell you that more and more tests are not being covered. And I don't really care who's president and who's in charge of Congress. This is a trend that's been going on for several years now. We're paying more and getting less. So we have to assume a little financial responsibility on our own. So that's what a medical advocate, what we believe in and what we should be doing. And I want to give you a couple of questions, and I want you to then give me your questions. Now, I'm going to give you 3 patient questions that are real questions. One patient told me this one. I'm really confused about supplements. My primary doctor doesn't believe in them. My chiropractor has put me on a bunch of standard process supplements, about 8 in total. And now you, meaning me, want me to take additional supplements to lower my blood sugar as well as stuff for my heart, something called 𝗗𝗲𝗃 X. I'm totally confused and overwhelmed. What do I do? Okay, so this is really pretty common because this issue comes up quite often. And first of all, this person hasn't really embraced medical advocacy as of yet, because she's going to a doctor that doesn't believe in supplements. Now, you don't want to hide that fact for your doctor, but you want them to be able to accept what you're taking. If they don't believe in them, then maybe you're in the wrong place. I had one person come in with 2 shopping bags of supplements. I mean, there must have been 50, 60 different supplements in these 2 bags. And I said, does your primary doctor know about this? She said, oh, no. If he knew about this, he'd fire me. He doesn't believe in supplements. I said, okay, who's paying who here? You get my drift? So that's one aspect. Then she goes to a chiropractor who put her on a bunch of standard process supplements. Now, nothing against standard process. I don't use them personally because I find them very cryptic and difficult to understand, and I would have to take a whole course in standard process 101 in order to appreciate them. But she doesn't even know why she's taking them. Okay, then I come with 2 new supplements. One is to help lower her blood sugar, which is kind of important because she's a pre-diabetic and she's overweight, and I'm trying to avoid starting her medication. So I have a supplement that I call 𝗗𝗀𝑖SE Plus, which has an herb called berberine in it, and also cinnamon and chromium, vanadium, alpha-lipoic acid. Anyway, it's a concoction that I put together to help lower blood sugar naturally, without medication. And then this 𝗗𝗲𝗃 X is based on a genetic variant that she has, and she has very high 𝗗𝗲𝗃 levels, which we'll talk about another time. So I did recommend 2 supplements that she was not taking, but they were for a specific reason. So when it comes to supplementation, you want to take everything but the kitchen sink. You want to take what's targeted for you and your goals. Second question, the patient asked me this. This is a good one. My doctor has been after me for the last 9 months to start a statin to lower my cholesterol. I'm not overweight. I have no family history, and I don't have a heart problem. Is this really necessary? And this person's acting like a real medical advocate. He's questioning the need to start a statin. And no history of heart disease. He's never had a heart attack. He hasn't had a stent. He hasn't had bypass. He's not a diabetic, basically healthy, but his cholesterol has risen steadily over the years. And before I even would try to answer that question, I would try to stratify his risk. I do what's called advanced cardiac testing, and we'll talk more about that next month, February, which is Heart Month. But he has every right to question whether or not he really needs to have a statin. The doctor, by the way, didn't mention anything about diet or lifestyle, just said, let's just go straight to this medication. So that's really being a medical advocate. He's questioning the need for that medication. Here's that one that recently happened, and this is very common now. I'm really scared to take the vaccine for COVID-19. I don't know what's in it. I heard it can make you infertile and it can cause convulsions. This really frightens the hell out of me. Okay, now I like this part about, I don't know what's in it, but do any of you eat bologna, or how about like processed foods, things in boxes and bags? Have you read the ingredients? Do you know what you know what you're eating? When you see things like numbers and colors, do you think that's healthy? So here's the thing. People were worried about what's inside a vaccine, and but it's like double standards. They're not as concerned about what they eat. Now, I will tell you that this vaccine has been studied. Like, it's too new. It's too new. Yeah, it's new. This pandemic's not quite a year old, but we need to do something about it. And believe me, it has been studied extensively, and I do believe it's effective. This infertile, this convulsions, anybody can develop a side effect of an inoculation. I really think that it's really safe for the majority of people taking them. I really do. And as far as these pictures on the internet of a nurse who came down with a convulsion 2 hours after she took the vaccine, and I mean, my one piece of advice to all of you is don't use Facebook or TikTok as a means of educating yourself about a vaccine or anything really medical or scientific. You have PubMed, you have the CDC, you have real scientific sites that you can really get that information from. So again, being a medical advocate is doing your research. What's really in this vaccine? How can it help me? Do I want to be living under masks for the rest of my life? And some of you young people might not remember what it was like with smallpox and with polio. Smallpox had a mortality rate of 30%. Okay, and that's been eradicated. The last time a vaccine was used was 1972. Polio was a big, I was a little kid growing up. I remember people having polio. They were paralyzed. They were in iron lung machines. It was pretty gruesome. And they were both viruses, both smallpox, which is airborne, like COVID-19, and polio were viruses. So we don't even hear about them today. But some of us that have been around for a while know about that. So my point here is do your research, know what you're doing, and know what you're not doing, okay? And don't believe everything you hear on the internet, especially if it's from Facebook or TikTok. So those are 3 examples of being a medical advocate. So now I'd like to see questions that you guys have. I have to put my old glasses on here so I can see the screen. Okay. Okay, what does one do when 2 members of your dream team don't agree? One is going to be pissed off. Okay, good question. Well, that's going to happen. Not everybody does agree. And I don't agree. A lot of people won't agree with me, and I don't agree with everybody, but I try not to be divisive. And the last thing I want to do is confuse my patient, to make them feel like they're in the middle of something. So I will bend. I will bend sometimes if I think that we're just differing a slight amount. As far as a huge amount is concerned, only if it's life-threatening or something that's really bad. But most of the time, I don't think this really happens for me. I just go above and beyond as a medical advocate, as an integrative doctor. So this doesn't usually happen to me, but it will happen to you, especially if you have a doctor who's totally traditional. And the way I put it is that I'm no better or smarter than the traditional doctors. I just think differently and do things differently. So as you go through your own selection process and making your own dream team, you will probably find that there are more similarities and differences in your dream team members. Okay, how effective is the COVID vaccine long-term protection against? Okay, so that's a great question. And we do know a fair amount about COVID-19 vaccine. After the first vaccine, you have about 54% immunity in about 14 days. The second vaccine is usually given at 21 days if it's Pfizer, and I believe it's 29 days if it's Moderna. But you need that second vaccine to push the envelope to get 95% immunity. Now, how long it's going to last, we don't quite know that yet. That is a of unknown. It is thought that you will probably have long-term immunity. We may find out later that we need to have booster shots. It may be once a year. It may be once every 3 years. We do give booster shots with other immunizations. So we don't have all the answers yet. So I'm looking to the authority. Yes, I look to Fauci. Yes, I look to the CDC. Yes, I look to my infectious disease colleagues, because they're the ones on the front line with this virus, and they're the ones that are going to hopefully get the answers to those particular questions, and they will be forthcoming. Okay, the shrink shop. Is it true that doctors are required to suggest push medication if a patient's number is out of range? I'm thinking about statins. Great question. I've never felt pushed to prescribe anything. Even when the pharmaceutical reps come to my office, knock on my door, and they tell me about these new medications, I listen with a jaded ear and eye. But it's funny. It's so indigenous to our educational process that you almost feel pressured, but I don't feel that way myself. I think it's really incumbent on the physician themselves to make these kind of decisions as to what to use medication at all. I have never felt the need, but at the same token, I will tell you that I'm not anti-traditional medicine. If I have a diabetic, if I have a patient with coronary disease who's had a heart attack or a stent, they're probably going to go on a statin. I mean, it's not that I'm anti-traditional. It's just that I like to think of alternative therapies. So personally, I have never felt that kind of stress. But again, I think it's more indigenous to the process, the educational process, that we are taught to use medications. It's like we're taught more about pharmacology than we are about physiology. I want to know how things work as opposed to just how drugs fix the problem. Hope I answered that correctly. Anybody else? I'll think of another one too. I always get this question. Always get this question. Okay, so what's a heart healthy diet? Which, by the way, is an entire lecture by itself, entire presentation. So I always, and this is when you really need to be your own medical advocate. Because if someone tells you that ketogenic or paleo or this new one called carnivore is the end-all be-all diet, you should probably walk the other direction, because there's no such thing in my book as an ideal diet. It depends on what your goals are, what your medical history is, if you have any food sensitivities, your gut function. There are so many aspects to what an ideal diet is for an individual patient. There are no hardcore rules, just like there are no hardcore rules for certain medications and statins. So I try to get as much information as I can about a patient before I prescribe or recommend any type of diet, supplement, or medication. Okay. Anybody else? Any other questions? Okay, here's a good one. Is the new blood pressure number of 116? Is the new blood pressure measure number of 118/68 a reasonable number to achieve? Absolutely. Okay, it's a great question. Thank you. So when I was a student many years ago, 140/90 was considered borderline, if you can believe it. So we never treated it. In fact, we never treated systolic blood pressure, the higher ones, because we were under the belief that only thing that really mattered was the diastolic or the lower number. But that really, we found in the 80s, there was a thing called the SHEP study, systolic hypertension of the elderly population. And we found, without a shadow of a doubt, that the upper number or the systolic number is just as important as the diastolic. So let me just make that's this historical thing that only someone my age would remember. About, I think it was 2017. There's several revisions, 15 or 17, in which there was another study that came out whose name I don't remember. And that the new standard became anything greater than 130/80 would be considered hypertensive. So if your blood pressure is 131/81, you are now considered hypertensive. But there's even more evidence to suggest that the numbers are even better if you get closer to 120/70. So what do I do in practice? Do I try to get everybody in those numbers? Absolutely not, because I would have to give a lot of patients 3 different medications. And then I have to worry about side effects, people falling and getting dizzy and other kind of problems. So I use what's called common sense when I treat hypertension. But I will tell you, with 35 years experience, that people that have lower blood pressures definitely do better. They have less heart attacks. They have less strokes. It's still the #1 risk factor of heart disease. So I'd like to go 130/80. I don't try to go lower. It's better. If it's someone who's young, who has a definite cardiac problem, I'm going to try to go a little more aggressively. But a person who's in this senior age group, I'm going to be more judicious, more careful about how low I go. But yes, it is important to go low safely. Okay, I have a hard time believing that blood pressure meds are not very effective. It seems no matter what I do, my blood pressure is not stable and not well controlled. Okay, that's interesting. So this person is saying that he's had great luck with blood pressure medicine, so he's taking a lot. Has it really not really been effective? That's not the majority. Most cases that I have and treated in my practice, I can get the blood pressure pretty much within control range. Not always, though. I do the best that I can. I do the best that the patient will do. There's also a problem called compliance. So if your patient's not taking the medications, you can offer all you want. Then I look at things like diet. Not that I think you have to really have a low salt diet, but I think there are supplements that are useful. Potassium is very useful in lowering blood pressure. It's seen in fruits and vegetables. Also, magnesium is important, coenzyme Q10, and I also use fish oil. And all 4 of those can be very useful in helping to lower blood pressure naturally. In fact, I always go to those first before I even start medications. So where do I go with that? It's not a cookbook method, like I mentioned. I just keep trying to control as I can. Sometimes it's difficult, but I would say with my experience, I have more luck than not. So it's finding the right combination of medications. I've seen doctors use 2 medications of the same family, which give more side effects. I don't know. It's usually not a problem that I normally see. Again, it's lifestyle. Or is the patient exercising at all? Movement is very important when it comes to lowering blood pressure. Really important. So that's, it's really a combination of lifestyle and medication. Okay, let's see. We have a few more minutes. I'm going to make sure I answered all the right questions here. Okay. So one that I missed. Thank you. I'm sorry. To reduce blood sugar, you said berberine. Yeah. So berberine is an herb, and some studies have shown that it is as effective as metformin, which is a very good, usually a first-line medication for lowering blood sugar. And berberine has less toxic effects on the GI tract. It's very well tolerated. So I use that in combinations with cinnamon, which is also decreases blood sugar, chromium, and alpha-lipoic acid. So what we're trying to do is to improve your insulin sensitivity. As you know, most type 2 diabetics or adult onset diabetics actually they're insulin resistant. Their body doesn't recognize their own insulin, so they make more. And then it compounds the whole problem. So the role of supplementation is to see if you can get off this roller coaster of insulin resistance, lower the resistance, and lower the liver production of sugar. And I think you do it quite effectively with supplementation, but it's really diet. I mean, one common thread with all my diet instructions is every diet should be basically low carb. There's no question about it, because that really is the of our existence. Okay, let's see. I work for a rheumatologist who would like to recommend alternative medicine, but would not want to do so until before thoroughly researching. This takes a lot of time. Do you have a recommendation to start? Yeah. First of all, there's a couple of organizations. Like I trained for the American Academy of Anti-Aging Medicine, and I did a fellowship that I enjoyed very much. There's another one called Functional Medicine. I think it's called the Institute of Functional Medicine. You can get all the information online. So it's not only for doctors, it's also for nurses and chiropractors. So people that really want to bone up on functional medicine and some of the anti-aging practices, there's really some great materials out there. But those are the two main organizations, the American Academy of Anti-Aging Medicine and also the Institute of Functional Medicine. Good question. I'm glad that your rheumatologist has that desire because, and I think it's really important these days. I think patients are demanding more. I know people that come to me usually come to me for that reason, because I'm not going to just tell them my medication. Yes, we do use medication, but we use an integrative approach. And like this whole thing about medical advocacy is concerned, my whole goal is to get them involved with their own process. It's not a one-way street, and it really allows for a really good patient-doctor relationship, which I'm very proud of. That's one of the major advantages, but that's great to hear about your doctor doing that. Okay, let me make sure I haven't left anything. Anybody have more questions about COVID? That's always a big one with the vaccine. I'm not an expert in this, but I've done my research, so to speak. I don't know it all, but if anyone has any questions while we have a couple minutes left. Okay, well, I guess that's it. Oh, it's good. Here you got one. Okay, the new vaccine. You've heard about this new variant. This new variant originating from Britain, I think, was from the UK, and then it was seen. I don't know if this was California first and then Oregon. So it's a new variant. It tends to be very contagious, and it seems to attack more young people than elderly people. It's not any more virulent than the garden variety COVID-19, but it is felt that the vaccine will cover that. Yes. And so I don't know much about the new one yet. Like I said, it started off in the UK, but it is felt the new virus will cover that. So that it should give us a sense of relief there. Okay. And so, yeah, I think we'll be learning more information about that, and I will certainly keep you guys posted as I learn more. The other confusion is where do you get the vaccines? And that's going to be, we have a new administration now, so I think one of the major thrusts would be to get these vaccines available to the people that really need it. And hopefully, I forgot how many vaccines he tends to get in the first 100 days, but I hope it happens, because it's very confusing. Even as a medical professional, I'm very confused. Like, I don't know when I can tell you or this patient or that patient when and where they can get their vaccines. We get at least 10, 15 phone calls a day in my office. And right now they're still doing medical workers, medical office workers, hospital workers. And I think that's still being done. And the next tier will be those over the age of 65, and also people in nursing homes and assisted living. But it's very confusing. So don't feel bad if you're confused. Okay, I've heard more reactions to the Moderna too. I've heard that too. I don't know if it's really true. the vaccines aren't notably different. One freezes in colder temperatures than the other. And when you give it 21 days versus 29 days, but they both give pretty much the same immunity, and that's what you're looking for. You want to have immunity, and they both seem to be pretty much equal on that. And that's really what you really care about. As far as more reactions, we don't know about that yet. I've heard anecdotal studies, and I don't usually get off on, unless I really get facts and figures, and something like that. So, but I think they're both effective, and I would not recommend waiting for Pfizer or waiting for Moderna. Whatever's available for you, to you, is what I would suggest from a medical standpoint. Okay, I think I got it all here. This print's really small, so I struggle a little bit. Okay, I think we're about done. So listen, we've been a half hour. So listen, guys, thank you so much for joining me. Great audience, and I hope you use these principles. And I always end with, whose body is it? It's your body. So stay in the driver's seat as you become your own medical advocate. Okay, thank you so much, and we'll see you in 2 weeks. Good night. And okay.